Onc Live Insights is a video editorial program produced by Onc Live.
What is the optimal use of Blinatumomab in ALL? Currently, I think it's mainly used as a single agent, the way it's been FDA labeled and approved in relapsed refractory Philadelphia chromosome negative acute lymphoblastic leukemia. In my personal experience, we've been using it quite extensively in relapse settings. My personal experience somehow reflects the published data, and I'm actually quite happy with some of the results I saw in some patients with Blinatumomab. It's certainly correct to assume that down the road, Blinatumomab may not be isolated in that setting. I don't see it so much as a frontline drug. At the time of diagnosis, one problem with Blinatumomab or with immunotherapy in general, and you can expand that to the CAR T-cell programs as well, is that they are not easy to use in patients with a high tumor load, say patients who present with a high white cell count, who have a lot of disease in other organs, as the toxicity can become quite significant. So it's usually better to use those agents after some sort of debulking regimen prior to it. That does not have to be particularly intense. It can just consist of steroids or steroids plus cyclophosphamide. But in some sort of sequential fashion, you could indeed think about the use of Blinatumomab following some intensive chemotherapy induction, say hyper-CVAD, 1 or 2 cycles, and then sequentially use Blinatumomab to mop up residual disease and solidify a response. You could even think that you may not need such intensive induction regimens to start with, and that you could get away with lower intensity regimens, which may be a more attractive option in elderly patients who suffer more from toxicities of intensive chemotherapy at any rate. Now, Blinatumomab is a very effective drug in eliminating minimal residual disease. In that sense, it may very well have a role prior to hematopoietic stem cell transplant, as plenty of data have shown and continue to show that patients do best after a transplant who go into transplant with no evidence of minimal residual disease, as opposed to still have evidence of it. You may look at it as a possible consolidation or maintenance treatment after transplant. That's certainly a possibility as well. I've even heard people say that they use it as sort of a quote-unquote debulking therapy prior to a CAR T-cell therapy. So there are plenty of opportunities of using Blinatumomab in any of those settings. There now is evidence presented at the ASH meeting in 2015 as well that Blinatumomab is also active in patients with Philadelphia chromosome positive disease. This was a study of, I think, 45 patients. The median age was about 55 years. All of those patients had relapsed refractory disease and actually quite extensive exposure to a number of kinase inhibitors, second and third generation kinase inhibitors. A good number of those patients had a prior stem cell transplant, and a few of those patients even had the usually highly resistant T315I mutation. What the results showed was activity very comparable to the one established in Philadelphia chromosome negative disease, with a response rate of around 40%. More interestingly, maybe the response rate holds up in that range of 35 to 40% if you look at subtypes of patients, for instance, those with T315I mutations, or those with, say, at least 2 or more second generation kinase inhibitors prior to getting Blinatumomab. There's also a substantial rate of minimal residual disease negativity, at about 80%, and relapse-free survival or disease-free survival comparable to what's been established in previous studies of pH-negative disease. So I think it is as well a very active drug in pH-positive disease, and I think it should be approved for that indication as well.